So we would sometimes do tests under code numbers.
I like
we would
that.
use
I
a
didn't know
yeah.
that. Yeah.
This is Snoopy Dog.
Yeah.
Charlie Brown
like
is
that.
is getting this test, and we would just. Welcome to the Dr. Gil Show. This is where we talk about medical matters that matter to you. My guest today is Andrew Illiff. Good evening, Andrew.
Hey, thanks for having me, Gil.
Dr. Illiff is a friend of mine and a colleague. Andrew is a local hematologist and oncologist. He treats patients with cancer. He's also board certified in internal medicine. And I just learned that the certifications of hematology and oncology are separate. So you're actually triple boarded.
I guess, yes. Yes, I would be triple boarded. It sounds more impressive when you
Sounds more impressive. It's one more than I have.
I haven't told people that. I should walk around and just be, I'm
Yeah,
triple board
put it on the
certified. It
sandwich
sounds
board.
great. Yeah.
Yeah.
So board certifications for oncology, hematology, separate board certifications. Most fellowships in the United States, they combine them into a 3-year program. There are some places that either do 2-year programs just in heme or 2-year programs just in oncology. But most people you probably see outside of select academic centers are probably board certified in both hematology and oncology.
In both. Cancer is just such a scary thing. And I remember when I was a kid, I'm old enough to remember, classmate in junior high, I think it was she, started getting some bruises on her skin. And months later, she was dead from the dreaded leukemia, Used to be you got cancer, it was a presumed death sentence or something like that. And in my career, or my life up until now, I have seen the most amazing advances in treatment. And now you and your colleagues in your field cure cancer every day.
Yeah, no. I mean, there's no doubt that like when I think about it, I almost think that we're just at the tip of the iceberg as far as where we are. And that we certainly have come a long way compared to wherever we were, 30 years ago. There's so much work to be done. But yeah, I mean, there's no doubt that when you're seeing a malignancy today, as opposed to even 10 years ago, but certainly 30, 40 years ago, that it's a completely different game that we're playing.
It's a different game now. Now, you've been in practice now about 5 years.
Yep. So 5 years and change now.
So I got about 30 years of practice on you. And I knew in the infertility world, when I was a medical student, I knew it was a nascent and early thing. And I knew there was going to be incredible progress. I got to tell you, though, when I was a medical student and choosing my field, oncology just seemed so daunting and so difficult and so complex. I didn't think I could do it.
Yeah.
I didn't think I could do it. So I really admire you and your colleagues for being able to put all this together, the internal medicine, the science, all the stuff that you all do. And there's even a specialty of oncology called radiation oncology. Yeah. So that's a whole nother world too.
No, totally true. So radiation oncology, and it's a completely different training background, kind of how they get to where they are. So it's a completely separate field, which is just its own unique field where they're doing a lot of cool stuff in radiation oncology as well.
And in a big group like yours, you have some radiation oncologists on the team, don't you?
Yes.
So it's a multidisciplinary thing.
Yeah, absolutely. And I mean, it's so, like, I think the collaboration between certainly radiation, medical oncology, that just having that constant ability, like they're just right down the hallway. So it's an every day that we're walking past each other being like, hey, this is going on. What do you think about this?
Right.
Which is so important in the field. So.
It really is. It really is. So I'd like to talk about in this segment, Andrew, our blood tests that we use to find cancer, detect cancer. And I want to go kind of in historical order, starting with the early ones we had, what they could do. And I want to advance. And at the end of this talk, I want to talk about some fascinating, amazing new tests that have just come online that, once again, I think are revolutionary. And I think you can explain them to me. So let's start out in the old days. Let's remember that when I was young and a kid would get some bruises, or they'd be losing weight, or they'd just be otherwise healthy person. There's some basic blood tests. We still get them that look at the number of blood cells, the types of blood cells, in the blood, and blood cells mainly come from bone marrow, where a lot of these cancers can start and grow. And we also look at metabolic panels, looking at the liver and the kidneys, and if something was in the liver wouldn't work as well. So these are very non-specific. So is there much role for these old tests, the complete blood count and the complete metabolic panel? Do you still ever use them?
I mean, as screening tests, they have basically no utility, to be honest with you. I mean, and it goes back to the historical basis of what a CBC is, right? I mean, that it would have just started with somebody taking blood, smearing it on a slide, and looking underneath a microscope. So there are some cancers which certainly are readily, identified on just a CBC. That it's, at least once a month that I end up seeing a patient who just had CBC at their primary care's office, just doing their routine blood workup, and is found to have an elevated lymphocyte count. And they probably have CLL, which is just an indolent, slow-growing type of leukemia. So we'll find those, but as a general population thing, that most of those tests are obtained for other reasons, and then we just stumble into it.
Just happen to find it.
Yeah. So, but for other cancers, like colon cancer or something like that, that the role of a CMP for finding a colon cancer is going to be pretty low. That until something drastically is abnormal going on, you probably aren't going to pick that stuff up.
I'm going to pick that up. So those have almost no utility unless you find something that's so obvious that you happen to pick it up.
Most of the time, the patient's coming in saying, I got a problem here. And then the CMP is just pointing further towards that problem.
I see. Now, are there ways that you can flow these cells? These cells can go through machines and they get sorted into different categories and whatnot. I think you get patterns. What is that? Is that flow cytometry?
Exactly.
Is that right?
Yep. So flow cytometry, especially in that hematologic malignancy world, is going to have a lot of use just picking up, identifying as far as what that type of malignancy is. So, for example, like that CLL patient that I end up seeing patient has elevated white blood cell count, and then the subset, which you'll get on just a differential, is going to be showing that all those are lymphocytes. So it's 90% pointing straight at CLL, depending on the patient. But I'm picturing some 80-year-old guy who has an elevated lymphocyte count. So flow cytometry, basically what they're able to do there is it runs it through a specialized machine where they're able to look at all the antigens on those cells and see, is that one lymphocyte all the same lymphocytes?
So different types of lymphocytes have these different proteins or sugars on their surface. Those are called antigens.
Yeah.
And you can pick those out and see if they are, for example, B cells or T cells or whatnot. And that gives you, allows you to do your diagnostic workup and with the treatment. So that's one way. Now, let's move on to things that are called tumor markers. Tumors can release various chemicals into the blood, and these can be picked up. But until fairly recently, a lot of these markers were something called specific. Cancer could raise this level, but other things could raise it as well. Saturday Night Live, famous comedy show, had some very famous actors.
Loves
SNL. And many of them have now passed on. One of them was Gilda Radner. She was famous for being the wife, I think, of Gene Wilder, where they fell in love and they were married, I believe. I could be getting this wrong. And she died of ovarian cancer. And I believe Gene Wilder, and I could be getting this completely wrong, or her spouse, went on a crusade after she passed away, saying, why aren't we measuring this marker in the blood, screening for cancer? Because ovarian cancer, like other common cancers, are frequently not picked up until they're very advanced. Ovarian is usually picked up stage 3 or 4, which are these severe. Now you already have all these other symptoms. And what he didn't understand, he meant well. What people don't understand is that other things can raise this. I do a lot of treatments for something called endometriosis and fibroids. I do surgeries for these things, and they have elevated CA-125s. Now, generally, they're not as high. But there's this tremendous overlap. Everybody's got some. It's never zero. There's all these conditions that have slight to moderate elevation that are not cancer. And then as you get into the cancer and the more advanced cancers, it's really, really high. So tell us, well, why is this not a good test for screen? Let's just talk about this particular, not good for, it seems on the surface that this would be a great test. Everybody should get it.
Yeah, absolutely.
Right? So what's the problem with these things?
And that, I completely understand that urge and that, inclination that it was elevated here. Why weren't we checking that 6-12 months ago? Whatever it was. But it goes back to your point. Just a non-specific test, that when you get a non-specific test in a patient who didn't need to get the test in the first place, that there's real harm that you can inflict on patients.
Explain that.
So let's say every 35-year-old woman ends up getting a CA 125 just routinely when they walk into their doctor's office, that you're going to find a good chunk of those that are going to have an elevated CA 125. So think about the anxiety that you end up causing for that patient.
And they don't have disease.
Yeah, it's a 35-year-old woman who's got 3 kids at home. Everything's perfect. Everything's healthy. And then you said, I don't know, you might have ovarian cancer.
Right. And in essence, it's what's called a false positive.
Mm-hmm. Yeah.
These are not black and white tests.
No. So that's a medical harm that you just inflicted by getting a test.
You scared them.
Oh, absolutely.
They're now getting unnecessary tests, possible unnecessary surgery.
Yeah.
Which harms people. People can die from that. And they didn't need it in the first place.
Exactly. So that's the downside of that. Sure, could you hypothetically pick up some woman that had stage 1 ovarian cancer and that you changed the course of her life? I suppose that's possible. But you have to think about it on a population base, which what we're talking about with a screening test is a whole population that you're going to end up hurting a lot more people than you're going to end up helping.
Right. So as these, and we'll once again talk about these more modern tests, it's very important to have what's called specificity or accuracy. Yeah. You can talk about true positive, true negatives. There's a whole world on what you call these things. But a term everyone should understand is accuracy. Yeah. Does a test that comes up positive, does it really tell you have a disease with high probability, and is this something you should act upon?
Yeah.
And this isn't a blood test, but this Cologuard, this colon cancer screening test that you test stool, it took a long time to develop because they needed something that was specific, something that was sensitive enough and specific enough that a general population can do the test and the benefits outweigh the harms.
Yeah. Yeah.
So there's these markers we can measure, and a lot of times we'll use it to follow progress of disease.
And that's really where tumor markers have their most utility to me is I know a patient has metastatic cancer and I'm able to get a tumor marker at the beginning of treatment. And then I'm able to mark that progress as we go along, which can help me. I typically, what I say is that this is just a hint. This is not, I'm not putting any 100% that I never make a treatment decision based on a tumor marker because it's just a blood test.
Right.
That I need more than just a blood test to be completely changing my treatment course. I mean, maybe there's some unique situations, but by and large, it just allows me to gives me probably a bad surrogate marker so that I can track how things are going, and give me a hint that maybe if the tumor marker is spiking, maybe I'm expediting a scan or something like that to look at things.
Right. But now, I deal with a lot of infertility, and I see guys who have illnesses, and sometimes they have testicular cancer. Mm-hmm. And sometimes these testicular cancers come from really bizarre cells called embryonal cells and whatnot. And they secrete really bizarre things that you normally don't see in a guy. For example, you can even have pregnancy hormone from these cells. So frequently guys treated, they take out the testicle and all the lymph nodes. It's called a radical orchiectomy. And sometimes that is the treatment and you can cure it.
Yeah.
But now you can measure these blood tests, these markers.
Yeah.
And it should be virtually zero.
Yeah.
And if it's still positive, it's still in there, you've got to assume in that case that there's residual disease somewhere else.
No. And you hit it exactly right. So the major utility is tracking treatment and then screening for recurrence. So somebody who had testicular cancer, you knew that their beta HCG was through the roof at the time of diagnosis, and then you've done some treatment, it's gone down, normalized, and then you can monitor that over the next 2 to 5 years. And if it starts spiking again, it can give you a hint that maybe something's going on.
It's coming back somewhere.
Why does this male have a beta HCG?
Right, a pregnancy hormone in a guy.
Exactly.
Right. Yep. Right. So That's good. That's good to understand. And that's why these tumor markers have not been offered as screening tests to the general population.
100%.
Because the harms outweigh when somebody otherwise has no symptoms.
Yeah.
And I've talked about this before, but I think about 15, 20 years ago, they used to offer CAT scans at the mall. You'd go down the hall, they'd say, "Get your CAT scan here."
Is that really true?
Yeah, they had semi-trucks out in the parking lot with CAT scans.
Random people.
And they'd put people through these scans. Oh, $300.
Yeah.
Here's CAT, $300 cash. And see if you have cancer. And they made them stop, I believe, if I'm once again remembering correctly, because they would find things. They're called incidentalomas. Yeah. They would find benign tumors. So all these people were getting terrified, getting scared, getting unnecessary surgeries.
Yeah.
Anyway, it's the same idea.
Yeah. Oh, I didn't know that. That's horrifying.
Yeah, you're young enough. Yeah.
There's people that are now doing that with MRI.
Yeah,
the exact same thing.
And for early pregnancies too, get your 3D ultrasound at the mall.
At least with MRI, you aren't radiating everyone. You know, with a CAT scan, right? You're giving them.
And back then it was more X-rays.
Oh, I'm sure, it was horrifying.
Yeah.
So at least MRI. I mean, that's a whole different bag of worms. But yeah.
So help me. There is a tumor marker called prostate or prostatic specific antigen, PSA.
Yeah.
And prostate cancer is a very common cancer. And I think the statistic is if a man lives long enough, like into your 90s, like 70% of old guys will get some type of prostate cancer.
Yeah.
And most of the time it grows slowly. But there's bad prostate cancers. And prostate cancer, this PSA, is released into the blood, and it can be detected via a PSA test. And I don't know if it was 10 years ago, 20 years ago. I think it was all the rage when a guy, and I remember going in for my routine physical exam, listen to my heart and my lungs, and put their fingers places you don't want. And they used to test for iron in the stool. Blood was called hematology.
Yeah.
Look, see, there's blood in your stool. And that was also so non-specific.
Yep.
Just putting a finger in there will make things bloody.
Exactly.
I mean, it wasn't very valuable. We finally stopped doing that routinely. But I remember that as a man in my 30s or 40s, they added a PSA to my CBC and my CMP, these normal screening blood tests. And I think recently PSA has lost its shine. It's not as popular as a screening test. So can you? I'm maybe hitting you this. I should maybe ask the urologist, but I bet you can tell me what's going on with PSA and why is the pendulum swinging away from it, if you can tell me.
I would say the pendulum is swinging back towards a center ground, where I think that I completely agree. There was a swing of this pendulum where it was just everyone's getting PSAs all the time. And it goes back to kind of that we were finding elevated PSAs inflicting harm by informing men maybe they have prostate cancer, doing biopsies that weren't warranted. So then there was this huge swing away from doing PSAs where we probably weren't doing very many of them. And I think that and part of that was I think they were saying that I don't think the mortality data had necessarily borne out that we were saving tons of men's lives by doing these PSAs.
Okay.
So then the pendulum has swung back to basically a joint decision model between a patient and a physician, where patients are informed about, hey, we're going to be drawing a PSA. Here's the risks and benefits about it. Is that something you want to be doing? Is that not? So, and then I think that helps kind of assuage that fear of, well, why is the doctor just calling me saying I got prostate cancer? That they understand what's going on. The doctor had already kind of prefaced the conversation by saying it's not a 100% test. So now it's very much in that joint decision model where patients and providers are having a real conversation about what's going on.
So I guess when does one get a PSA? If one's prostate is enlarged on your annual exam, or there's blood in your urine, or there's a family history, where does it come in then if it's not routine all the time or very rarely done?
Well, and it kind of goes back to that model that I think most primary cares, and I'm not in that space anymore, is more about that at a certain age, whether it's 50, 60, that there's a conversation that just happens. It says,
or at least there should be a conversation.
We have a screening test called a PSA that we could talk about. Here are the benefits. Here are the risks associated with that test. Is that something you're interested in? And I think there are plenty of patients to say, sure, throw it on there.
It doesn't sound like it should take too long, maybe a couple minutes.
Yeah. So, and but that goes back to the history of medicine, right? That I think that historically speaking, medicine was very a paternalistic field, right?
Yes, it was very particular, and it was mainly men.
The doc said, do this. There were no questions asked, and that's just what happened, right? And then I think there was this pendulum swing kind of even, 10 years ago where I felt like physicians were almost afraid to be like voicing their opinion, that patients just were, this is what I want to have happen. And now it's kind of swung to this middle ground where it's like, we just have to have a conversation. Let's talk about it. Here's the benefits, and then here are the risks associated with it. And that's kind of how I try to approach everything I do in my career.
Yeah, and most of our intelligent patients, everybody's got one of these, and there's the Google and the Bing and the searching functions and whatnot, and very good information from very good organizations out there. So maybe some not so good information. It's hard to sort through it.
No, I never try to shame a patient who said, I Googled this and I found something. Even the craziest of things, because if they found it, let's have a conversation, right?
Right. Or there's a new thing that I haven't even heard of yet.
Yes. Some doctor in, some country says that if I take this deworming pill, it's going to fix all of my problems.
Right.
Okay. Well, let's have that conversation.
Let's need to have that conversation. Exactly. Exactly. So I would like to move on to... Let's advance in technology here. Yeah. So let me talk about cancers that run in families. Mm-hmm. There are recognized mutations, and they have names and whatnot, that occurred however many hundreds of years ago. They're called founder mutations, and they run in various populations. Eastern European Ashkenazi Jews are famous for some particular diseases. French Creole that came through Quebec have some founder mutations. Amish here in the United States have their own interesting mutations that predispose them to various diseases. And there's genes are sometimes called oncogenes. These will, if you have one of these genes, it significantly raises your chance of having some of these cancers. And you see it on TV, that MEN2, multiple endocrine neoplasia times 2. I can't tell you how many drug ads I see on TV.
Yeah, I know, right?
Do not take if you have multiple endocrine neoplasia. Well, it turns out like all of these hormonal drugs can actually stimulate tumors in these people. So there are all these recognized mutations. One famous one is BRCA, for example. And if some of these diseases run in your family, you can have one of these screening tests. And generally it comes as a panel of 40 or more of these mutations. Yeah. So should someone just willy-nilly, if they're coming in for an annual exam, say, hey, doc, I would like one of these mutation panels. I want to see if I'm at increased risk for some of these cancers. How would you handle that question?
So, and it kind of goes back, that I agree that BRCA was kind of the first one that we ended up finding. Exactly. And the Ashkenazi Jewish population has a specific BRCA mutation that was identified early on. And then we found subsequently that within that BRCA gene, or BRCA, that there's tons of other mutations that are also pathologic variants that aren't shared by people with Ashkenazi ancestry.
So you can have BRCA and have it be a completely different heritage.
Yes. Okay. Yes. I think BRCA is independent regardless of your ethnicity, that BRCA is a strong, depending on which mutation you have, can be a strong predictor for the development of malignancy. But to your specific question, so who should be tested for these? And I think that's completely changing. That 10 years ago, the answer would have been you have to have just 75 family, something just crazy.
A strong family history, thyroid cancer, breast cancer, colon cancer, Lynch syndrome.
All over the place. And part of that would have been just realistically, to talk about the economics of it, is that insurance didn't want to pay for it. Right. I mean, so insurance didn't want to pay for it on, okay, I understand your great aunt had breast cancer, but I don't want to pay for that test.
Right.
And I think that partly has changed for two reasons, in that we're finding more of these mutations, right? And then partly just the economics of it is that the test is cheaper, so insurance isn't fighting nearly as hard
And
as
treating an advanced cancer is very expensive.
Yeah, exactly.
So as soon as the bean counters at an insurance company figures they can save some money,
all of our,
they will change their policy.
Yes, the arch enemy of every story. Insurance company.
Kicking and screaming.
Those guidelines are much more loose. So breast cancer, we don't want to just do it on everybody. Like if you has anybody in your family had cancer before? No. Okay. Well, then the chances of it goes back to pretest probability. What's your pretest probability that you're going to have one of these mutations? Probably 0. If you don't have any family members, you've got 17 cousins and none of them have had it, 17 great aunts, none of them have had it. Then what's the purpose of doing the test? But that guideline has become much more, looser now as far as who should be tested. So it's not as strong a family history as you would think. 2 family members with breast cancer, you get breast cancer, boom, you qualify.
Yeah, because you can get breast cancer or colon cancer without one of these.
Oh,
genes.
100%. Yes.
Right. Let's understand that.
Totally.
That environment, maybe 70% of these cancers are due to an environmental exposure or just bad luck that we don't understand.
Lung cancer. Is it because I smoked cigarettes when I was in high school and I'm 75 years old? The cigarettes you smoked when you were 18 probably are not the reason that you got lung cancer today,
Right.
So.
Yeah, so let's put a finer point on this. When testing for hereditary cancers, these mutations with these panels, is it fair to say that most of the time we will do it if there's a family history?
Yeah.
And some of these oncogenes, you can get one from your mom or one from your dad. And sometimes you want to know, well, my mom had breast cancer and had the BRCA gene. It doesn't necessarily mean the woman had it. She may have a 50% chance that she doesn't have it. So that can affect management as well. So you might want to know, did I inherit it?
Yeah. And most of the panels like that we use specifically at Missouri Cancer Associates, that is Invitae is the company. And it's really cool how they do it, that patient gets tested. Let's say they have a BRCA mutation. They offer complementary testing to all of your family members. So any family member that wants it, that you want to write down, obviously they aren't forcing you to share your family members' names. But if you want your, daughter to get tested, you just jot down their name. They send them a kit, spit in it, boom, they call them with results.
So it doesn't even have to be a blood test. You can get the DNA from saliva or other interesting places.
Yeah. So.
Well, that's an interesting value. Well, that's actually, that's a gold star. Good for them.
No. Yes, I would agree.
Good for them.
I think that is a good service.
Just from a business standpoint, that's good branding and value and community service. That sounds really nice.
No, it is good. And then if anybody had a specific question about do I qualify, I mean, we've got genetic educators on staff at Missouri Cancer Associates.
Can we talk about that? This is really important, Andrew. But let's talk about this now. There are lots of these tests where our strong recommendation is that you not get the test until you've been counseled.
Yeah.
Explain that. It's not that you get the test and then get counseled. You need to know what you're getting into, don't you?
Right. I mean, this is so it goes back to that I think it is important. And I think it needs to be by somebody who's trained to have those conversations. So
you have certified genetic counselors.
Yeah, exactly. So they basically have that conversation because it's a big test, right?
Right.
If you're going to offer it to a 19-year-old girl who's asymptomatic and you're going to tell her that she's got an increased risk for ovarian cancer, and then that's going to be impacting decisions about future fertility. Does she want to wait to have kids earlier? That's all that needs to be something that's involved in that conversation.
They need to be prepared to make those decisions. Yeah. And if they don't want to know,
then wait till
it's appropriate.
At an age where you want to have that conversation.
A friend of mine has a family history of a Huntington's disease, a horrible neurologic disease. And she knows she has a 50-50 chance of getting it.
Yeah.
She doesn't want to know. And I don't blame her. Because if it comes up positive, you're going to live the rest of your life in fear and what?
Yeah.
It might be better just not to know.
Yeah. Especially with Huntington. I mean,
it's just such a terrible demise.
Is just horrible. Horrible neurodegenerative disease.
Not a cancer, but it's the same idea here that you really need to know what you're getting into.
And on the flip side, there can be some empowerment, right? That by knowing these results, that you know, all right, well, I know I need to be getting, my mammograms on a regular basis, potentially MRIs in my breast, those conversations. Right. But it's all part of that you can't answer that question for everyone, right? Everybody has to be able to be in a situation where they're mentally able to work through that and decide what they want to be doing with their own life.
That's very, very important. Okay, so we need counseling before these tests. They are not black and white. Now, before I get on to the final super high-tech test that I'm very excited to hear about, when the BRCA test first came out a few decades ago, people were terrified.
Yeah.
And, for example, if the mother had breast cancer, we wouldn't test the offspring. We wouldn't test the daughter, who's my patient. We would test the mother.
Yeah.
So if she came in positive, well, maybe it wouldn't affect her life as much, because if you were found, you'd be stigmatized as a high risk or like a pre-existing condition kind of thing. Yeah. So we would sometimes do tests under code numbers. We would use this is Snoopy Dog. Charlie Brown is getting this test, and we would the person would pay cash. We do it under a coded name, and they'd have a secret envelope, and the information wouldn't make it to the insurance companies, so or the life insurance companies,
as they should.
So I think this is less and less of a problem.
Yeah,
but what are your thoughts on a diagnosis of oncogenic mutation in your bloodline? What are the ramifications, and what can people do about this?
Yeah, to Congress's credit, they did make a law about this.
Yes, I believe they did.
And the name,
was it part of Obamacare?
I feel like it predates that. But
it may have predated it.
It has one of those nice names, like all the laws do. But so it prohibits those companies from. I think there's a couple of specific carve outs, but by and large, health insurance can't ask it and then be like, well, you've got a BRCA mutation, we're not covering you, or likewise employers. That if you were to have one of those. So all that information is confidential. They can't ask for that.
Right, so there is a layer of protection now that wasn't around when these first came about. Because can you imagine, you've got a disease, right when you need health insurance, they pull it. Man, what a nightmare.
But that was definitely a needed law, because once again, I hate to bash on insurance companies.
Go ahead.
If they could pull the plug and we aren't covering that, they absolutely would have. So it's good. It's good that they did come up with something to protect patients.
Well, I'm also happy that they've gotten the price of insulin down. I mean, gouging sick people. Not a big fan of that business model.
Mm-hmm. Very true.
So, Andrew, I am going to move on to a new type of testing that you informed me of recently. DNA, the genetic information of our cells, and DNA can be regulated and turned on and off and modulated in various ways. And one of the ways DNA is modulated is with little caps. These were called methyl groups. And there are methylation patterns to various cells, and it's an enormous topic, and it affects almost every aspect of genetics and biology. But somebody found out that there are methylation patterns that are specific to various cancers. And I'm going to say one more thing. And it turns out these methylated DNA fragments can be found in the blood in a very sensitive manner, and that they can detect very, very small, minute amounts. And this now allows blood testing to see if someone has a super early cancer, and it can even tell you the type of the cancer. Would you tell me, what is the name of this test? And please tell us more about it.
Yeah, so Galleri is going to be the first one. So
Galleri, Galleri.
Exactly.
You can Google that.
Yep. Grail is the name of the company. Galleri is the name of the test. So Galleri is going to be they're the first ones to market. This is going to be a huge, I know that there are other people that are rapidly investigating this.
I'm sure there's patents, but people work around patents.
Yeah, exactly. So So Galleri is the name of the test. So it's a blood-based test, just like you were describing, it looks at methylation patterns within the DNA of your cells that you can just pull up on peripheral blood. And so this is looking at what genes are potentially, hyper or hypomethylated. And then they can track that based on historical databases of people who their blood had a similar marker and then ended up having a certain type of malignancy.
So with large databases, you come up with powerful statistical models and associations and start getting this incredible sensitivity we were talking about. It's my understanding this Galleri test is something like 99.5% specific or accurate, something incredibly high. I think the Cologuard test that I mentioned, colon cancer, is something like 97%, depending on who you're looking at. But it's got to be for the FDA and the governmental approval agencies to approve something. It's got to be up in the 90s.
Yeah.
And to see that this Galleri test can be something 99 over 99% accurate or sensitive, however you want to measure it, is really astounding, Andrew.
Yeah. So, and that's the idea. Blood-based test, they can reliably determine whether you have a cancer or not. In Grail, I think the name of the company was not incidental.
Grail, Grail.
I think the holy grail of cancer screening is what they're trying to at least market themselves as.
Sure, good choice.
Yeah,
good name.
It's a great name. So, and I mean, it's a cool test in that I think the initial people that they found, I think the company had set off to be a prenatal test. So
in pregnancy.
So it was a prenatal test, and at least the story that I've heard is that a few women during that prenatal testing, they had seen some very abnormal methylation signals on their blood. And then subsequently, when they followed those women years later, they had developed a clinical malignancy. And I think that gave them that we just stumbled into something.
Interesting, because when a woman is pregnant, the DNA from the pregnancy gets into their blood. It's called free fetal DNA.
Exactly.
This is a test that's done all the time. You can determine if there's normal chromosomes with high accuracy. It's not perfect. You can determine the fetal sex. That's almost the most popular indication for it. But you're able to get the DNA out. And with new technologies, not so new actually, it is amplified.
Yeah.
It doesn't seem like a lot, but you can double it in one cycle and then double that again in another cycle and double that. And pretty soon you've got enough to cover the planet. So you can magnify and amplify this signal and find amazing things.
Yeah.
So what kind of, boy, I have so many questions.
Yes.
So when would you get this test? So I assume if somebody walks in with an obvious tumor and you biopsy, you know what they have. The test isn't telling you very much. Is this going to be done as a screening test on otherwise healthy, outwardly healthy people? Where is this going to?
I think it's to be determined, right? So what they have demonstrated is they have a great test that's reliably able to pick up malignancy. What they don't have is, once again, what we're really looking for is, by doing this test, are you saving lives? Right? That's what you want.
Right.
That we don't want to just order a test and be like, well, you've got some cancer. It's not going to change
Now go
anything.
home and die.
Yeah,
right,
exactly.
right.
How do we
know? A nice day.
So, and there's a guy, Vinny Prasad, he's an oncologist at UCSF, and I think he said it really eloquently that with a test, broadly speaking, there's three types of cancers, right? There's a cancer that you might get, but it's never going to impact your life at all. So that'd be type 1.
Okay.
So a 95-year-old guy who's found to have prostate cancer, that probably is not going to impact his life.
Okay.
Test 2 is a test or type 2 would be a cancer that you find, and by finding it early, you can intervene and end up saving that person's life. And that's what Galleri is looking at, right?
It's the type 2.
The type 2. And type 3 is a type of cancer that you're going to find, and it doesn't matter when you found it. That cancer was on a path that it was going to end up taking that person's life, regardless of when you found it, which unfortunately are some type of malignancies.
Reminds me of triage. Yeah, those are the three categories. Yeah.
So, but that's what they're really looking for, and the data. And they have several trials in NHS in the UK. They do have a large trial where they randomized half the patients to be getting Galleri every year, half the patients don't get Galleri, and then you can track those patients longitudinally and say, did those patients who had a positive Galleri end up going on and living longer than those patients who did not get a Galleri?
That's really important. Obviously, would need a large population, but so many people. If you look at a population, you got thousands of people, and they don't get the test. They have car accidents. They have heart attacks. I mean, all kinds of homicide, suicide, all these things. So, so the number that are going to die of cancer kind of gets diluted.
Yeah. And I guess it kind of goes back to, but it goes back to that whole conversation. So who should get this test? So Missouri Cancer Associates, we are launching a Galleri program because I do think it's important that this test is available to the community, that if you wanted to proceed with it, that you should have that ability to do it. I mean, it's commercially available. But that I think that we have kind of a guideline set up of who should be getting this test and who should not be getting the test. And so a 20-year-old who has no health problems, really bad test for that person to get because their risk of cancer is so low at that point that it makes almost no sense.
So it's not cost effective, just the per dollar spent.
Well, and once again, now you're going to tell a 20-year-old that they had a false positive. Risk of false positives is very, very, very low.
But if the risk of disease is so much lower,
then you're going to end up getting false positives. So the idea is you have to come up with some, but going back to BRCA, maybe somebody who has a BRCA or P53 mutation that they, and then they're 60 years old, that would be a perfect person to do a Galleri on. That you can be screening for that malignancy if the patient's willing and interested.
So I'm glad you thought of guys. People have put a lot of time and thought into when to use this test. Was there perhaps an age? Like I know we're with breast cancer women, they recommend women start getting mammograms. It was 50 or 45 or somewhere in their 40s or 50s. That's when the chance of picking up one and having a true positive is significant. I know colon cancer, you're supposed to get your colonoscopy around age 50. Have they had any thoughts in a general population, if someone doesn't have a family history, otherwise have they had any thoughts? Well, maybe we should start getting this Galleri test at 30 or 35 or 40.
And I couldn't tell you in the NHS, so I think 50 would be a reasonable starting point to be having that conversation, unless you are younger than that and have some strong risk factor for the development, like having a BRCA or some other mutation.
All right, so let's talk about that. Yeah. Somebody has a BRCA mutation. They've got a MEN2. They have a Lynch syndrome, a colon cancer thing. Yeah. They have obviously colon cancer, you can get a colonoscopy. Some other cancers harder to detect way. So if you're at a higher risk, maybe you should start getting this test earlier. And the goal is to catch it early, right?
Yes, exactly. And I guess one thing before we go further, just for the audience that might be listening, is the status of the test right now is that the FDA has given it a green light, said, yep, you can commercially, market this test.
Okay.
That does not mean insurance is obliged to cover it, and Medicare is not obliged to cover it. And
that's another level
where we are right now. Exactly. Okay. So, and I think insurance and Medicare, all of these people are basically waiting on, show us some data that says that by doing this test, you're going to end up saving lives. And then I think they're going to be obliged to cover it.
And then there'll be a cost associated with it, and the bean counters will figure out, what's the cost benefit? Yep. Is it worth limited public funds?
But right now it's $950.
$950 cash price.
Cash. Yep. And that's what the test costs. So you said that Missouri Cancer Associates offers it. I assume you're probably the only place offering it. Yes.
You're not going to get this at your family doctor's office.
Yep, I would say so. Dr. Don Delwood, I'm sure you know.
He's a primary care doctor here.
So one of the concierge docs in town, fantastic primary care doctor. He's been doing this for 2 years.
Really?
Yes. So he was before I got. I mean, I think we both had heard about it, started talking about it, but then Don jumped at it, and he's been offering it within his clinic population for, I bet, 2 years. And interestingly enough, I ended up finding that he had his first positive.
So it's not like you're going to find lots. It's not like half that you're going to get this test and, oh my God, there's a huge chance I have cancer.
Like 2 to 4%.
All right. So if you're just walking around healthy, you get the test, maybe 2 to 4% chance they're going to find something.
Right.
So if it were negative, if you were to get one, Andrew, and it was negative, would that be reassuring to you?
Yeah, I think so. Yeah. I think it would be reassuring. I think my risk right now, is low enough that once again, that it wouldn't be a good test for me because I think my chances of having cancer is pretty low. But
because it's looking for about 50 or so of the commonest cancers.
Yes. So there's a huge list of cancers that they're looking for. The penetrance in those cancers is different. Like breast, prostate, colon, those are probably the least likely to be picked up on this test. But that being said, we have screening tests for that, right? We've got mammogram, colonoscopies, PSAs, things like that.
There's other ones that'll sneak up on you. Like I know what runs in my family is pancreatic.
It's a horrible cancer.
Horrible.
Yeah.
And you don't know you have it till you have it.
And so that would be a great kind of population to do it in. People who have strong family histories of pancreatic cancer. We don't have a screening test for pancreatic cancer now. We do know, hypothetically, the thought would be that by catching pancreatic cancer earlier, that hypothetically you should save that patient's life.
Right.
We haven't proven that.
You have a shot.
Right? Yeah, exactly. You got a shot. The Galleri hasn't proven that, but that's the idea right there.
And the data is coming. I'm sure that they've got prospective studies ongoing.
Yeah.
And I guess the same question applies, so I guess you kind of answered it. If you do have a positive cancer, is that going to go to your health insurer? Are they going to cut off your health insurance? Is it a pre-existing condition? Or, did you, before you applied for the health insurance or the life insurance policy,
I think they're on the hook. If you get a positive test, I think by that point, the die has been cast, right? That if you're on the insurance and then you get a positive test, there's no going back for insurance from that standpoint.
I think of people without health insurance, people go into concierge medicine, which actually, if you look at the cost of insurance, it's actually a pretty good deal. And you get to talk to your doctor more than 2 seconds. You actually get to chat with your doctor because they're getting fairly compensated for their time. So when you mentioned this test to me, I was actually considering it, but then I really thought through it. Maybe I should even talk to one of your counselors.
Yeah.
Maybe I don't want to know quite yet. I'm in my 60s.
Yeah. And it's just tough, right? I mean, that everybody's different in that. And I think that, one thing, just taking a one size fits all approach to everybody has different values. Everybody has different.
Yeah, isn't that true? I mean, there's a lot of, and I'm not saying this is good or bad, but there's some people say, hey, look, it's God's will. It's very popular here in my fertility world on the coasts. Every fertility patient gets tested for recessive genetic diseases. There's hundreds of diseases,
really?
And you got to sit in the waiting room and fill out all this stuff. And everyone is offered these tests, and they're not cheap. But almost nobody wants them here in the Midwest because it runs the family. If I happen to get it, it's a low chance. It's 1% or it's 2%.
Oh, I've never thought of that.
That's God's will. I'm okay. I'll take that risk. Almost nobody wants that testing here in the Midwest. Yeah, in the waiting rooms in Long Island or Hollywood or San Francisco, everybody gets counseled for it, and the majority of those patients get tested for these recessive genetic diseases.
That makes sense.
So it's values. It's a worldview.
Totally.
Not that one is right or wrong.
No.
They just are. So I think you raise a real important point that does a test and the result of that test fit into your life plan or how you deal with things.
Exactly. So, and I don't think that everyone would be interested in this test. But I think it goes back to that it's available. I think that this will, I fully think that in 10 years, yes, I think that this will be a test that is readily offered at your primary care visit every year you go. I truly believe that. And I say that I'm just hopeful that before it gets I think that hopefully that mortality data really pans out. And then I do think it will be readily available at primary care offices within the next 10 years.
I guess if it saves money, you might see insurance companies suggesting it. Gee, you better get your mammogram, your pap test, and your Galleri test.
Yeah.
And I assume if other companies are coming on board with this test, then you'll have competition, economies of scale, and like everything, price will come down.
Yeah.
Well, should come down.
Yeah.
We know that's not true in pharma.
Gets involved.
We know, right.
Complicated.
Pharma, 5 companies, and they all raise their prices.
It's just magically how that happens, So
amazing. So I want to finish with a final category of blood tests that you'd mentioned to me. It's called MRD.
Yeah.
Is it minimal residual disease?
yeah, exactly.
So let's say you've had a tumor cut out of your body and it's gone, or you've had chemotherapy and it's gone, and you've rung the bell and you're in remission. So there's blood tests to see if it maybe is coming back.
Yeah.
Tell me about that, MRD.
Yeah, so MRD has found its place into basically a majority of malignancies. Leukemias, lymphomas, MRD has been around for a while, where somebody gets, has AML, which is a deadly, horrible type of leukemia. They end up going off and getting their transplant. They can check for MRD in various ways to see
bone marrow transplant.
Exactly. So exactly. Excuse me. And they can check to see if there's any evidence of that leukemia around. It's finding its way more into the solid tumor world, where a patient, colon is probably the biggest place that it's used right now. Signatera is the name of the test. But so somebody has stage 3 colon cancer and you have resected the disease. Maybe you're probably giving them some adjuvant chemotherapy afterwards. And then you can check their blood with this Signatera test. And it can basically say that can you find, they take that block of tissue from the initial surgery, chop it up, look at all the molecular patterns of that tumor.
So it's individualized
Exactly,
medicine.
100%. Yeah. So this one's individualized to that specific tumor that you had. They knew that guy was in you at some point. And then they look, once again, looking at genetic patterns in your peripheral blood so they can match it up. That tumor that was in you, removed, should be gone. And then they can basically go back and look at that peripheral blood and say, hey, actually, I see a signature of that tumor still in your body.
And it's that sense, and it picks it up early.
Yeah.
So you could restart chemo or start looking for it again.
Well, but that's a great point, Gil.
Yeah.
We aren't there yet. We don't know what to do with these tests. They have a test. So it goes back to just like to Galleri in some ways, that we have a test, super cool, fancy new test that can say, yep, I found a signature of your blood that says, yep, you still have colon cancer cells in your body. But we don't have the data saying what to do. Is that person improved by screening them more frequently, by starting chemotherapy? To what end point are we starting chemotherapy or ending chemotherapy?
Right.
So we don't have that data yet. I think that's going to be interesting.
So this is a brave new world. It's not black and white by any means.
No.
And that's why we need expert oncologists like you and genetic counselors to guide us through this, explain these things, come on podcasts with this fascinating new information.
Yeah.
Now, before we wind this down, Andrew, is there anything on blood testing for cancer that I have not asked you about? Do you have any, for example, ideas for predictions where this is going in the future?
Yeah. I mean, no, I think you've hit it. The Galleri, I think that I think it's headed our way, that I think it's inevitable that it ends up getting approved widely within the next 5 to 10 years, and that it's something that's available. It's available now commercially, just out of pocket. And I don't know. I think it's going to be really, really interesting to see what happens with blood-based tests in the next, certainly even in the next 5 years. I think it's going to be, everything's going to change.
Well, in the computer world, it's called Moore's Law. Every couple of years, everything doubles in power and speed. Mm-hmm. And I think we can be virtually guaranteed with advances in genetics, molecular genetics, testing, all these things, that this field will continue to grow. And hopefully the bottom line will be we relieve suffering, save lives, and continue to have rewarding careers.
Yeah. Absolutely. I mean, cancer sucks. So anything we can do to decrease that burden on society is absolutely what we should be doing.
Well, what a privilege to have you in the community and to have you as a friend, Andrew. And thank you very much for your time tonight.
Hey, thank you so much.